We hope that you are learning a lot as we are about the various conditions that can affect women. Today, I'm going to talk to you about vein disease, and it's a very, very common disease among women. And I've taken the two most common vein disease among women, and that is varicose veins and pelvic congestion syndrome. So my title of the talk is Less Vein, Less Pain, and I'll explain to you why as we go along. Now, how common are varicose veins? Now, all of you know what varicose veins are. They are those green, big, lumpy veins that we see in the legs, mainly over the calf, sometimes in the thigh, and sometimes at the back of the knee. And it is a very common problem, more so for women than men, in about 67% for women and 41% for men. That's not to say that we don't see the disease in men. We do. We do see men having varicose veins as well. But it's far more common in women because of the risk factors involved. Now, what exactly are varicose veins? Now, all of us know that veins bring back blood to the heart. Now, arteries bring good oxygenated blood full of nutrients to the muscles, to your tissues and organs. And after the oxygen and the nutrients are consumed, the blood needs to go back to the heart and for recirculation to the lungs to get oxygenated again. And that is the job of the veins. The job of veins are to bring back blood back to the heart. Now, particularly in the legs or the lower limbs, now if you think about it, for us all, most of the time we are on our feet or we are sitting. Usually, most of us sleep for 6 to 8 hours a day where we are lying down, but for the rest of the time, we are upright, so to speak. Now, if we are upright, the blood flow in the vein is usually not very good. It tends to pull down because of gravity. But the way we are created is that in our veins, all of us have some valves in there. And these are unidirectional or one-direction valves. That means they allow blood to flow upwards, but not down. And that's how we prevent blood from pooling in our veins, especially in our legs. All right. Now, so in people with normal veins, the blood flow is fairly regular. It goes up, and this is aided by a combination of things, the presence of valves, as well as the presence of muscular contractions. Many of the veins travel with the arteries, which means they're surrounded by muscles. And as we move our legs, we walk, we tiptoe, we even stretch our feet, it squeezes on the veins to force blood back up. In varicose veins, the particular veins of the skin and fat where there's no muscle surrounding it. Now, those veins become defective. And how they become defective is essentially the valves fail to work. So as a result, there's backflow of blood. So the blood starts to flow back down and gets pulled in the veins, causing it to enlarge and over time become tortuous and big and ugly and green, like the ones you see in this picture here at the back of this person's calf. So the veins essentially over time become engorged. Now, there are many stages of varicose veins, and how do patients present with varicose veins? In the earlier stage, in which we call it C0, there are no usually big green veins, but usually we have small spider reticular veins. These are the small spider thread veins that many people complain about over their legs, especially their thighs and their calves. And then as it progresses over time, and this is a matter of months to years sometimes, the veins become enlarged and tortuous, the big ugly green ones. And that's about C2 stage. Sometimes there's very significant swelling because as the blood pools, it seeps out the veins into the surrounding tissues, and so the leg looks swollen. That's about C3. And over time, as the blood that is pulled and in the surrounding tissue breaks down, the hemoglobin or the iron inside is deposited in the skin, and it causes pigmentation or browning of the skin, much like rust in iron. And sometimes that can irritate the surrounding tissue, and it causes patients to get itchy, and they develop what we call a venous eczema, and they get a little thick staining of the skin. And in very, very severe cases, and these are usually what we see in people who have not been treated for long periods of time. That means they've had their varicose veins for many years, like 20, 30 years. Sometimes the skin breaks down spontaneously or after a small cut and doesn't get healed. And that's called a venous ulcer. And that's really advanced in C5, C6. So this is how we usually classify varicose veins, but I put this up so that you can understand and see what are some of the presentations of varicose veins. And some of you may wonder, do I have varicose veins? So it's time to look at your legs and figure out whether you have these. Now, what are the risk factors for varicose veins? The risk factors for varicose veins among women, the most common is multiple pregnancies. Now, we know that women who have had 2 or more children are at increased risk of developing varicose veins. We see, and the reason is because babies press on the iliac veins. The iliac veins are the veins that drain from the leg up back towards the heart, and so there's increased pressure in pregnancy, and they feel that that may cause those one-way valves not to function too well. Other risk factors include family history. We have got patients who are siblings and the whole family has them. We have not identified a gene, but we know there is in family clusters. People who are obese, who are overweight, naturally there's a lot of pressure on the veins, especially in the legs, and so the valves tend to malfunction. Patients who have vocations that require long periods of standing. So we see a lot of people who are in teaching, who are chefs, in that sort of job that basically needs them to stand for long periods, and they are also at risk. People who have had previous blood clots in their legs or previous DVT, that can also damage the valves in their veins and cause varicose veins. So these are some of the risk factors that are present. Sometimes we see in patients who have varicose veins none of these risk factors, but they develop them nonetheless. Now, what can we do once you have varicose veins? Now, usually we do an ultrasound to diagnose it, and once we do an ultrasound diagnose it, we can treat it. The simplest and easiest non-surgical way to treat it is actually to wear compression stockings. But the thing about compression stockings is that you have to wear them for long periods of time and forever. Now, it controls the problem but does not cure the problem. So essentially, a lot of people try compression stockings, which are very tight and they grip around the leg and compress the veins. But in our Singapore context, where the weather is warm, compliance is sometimes low. And when they remove the stockings, it all comes back. So if the varicose veins are very severe, we sometimes advocate doing a surgical procedure to get rid of the veins, and it's often curative. One of these procedures is known as radiofrequency ablation. This is a minimally invasive day surgery procedure, and we do it under local anesthesia with a really, really light sedation. And in this case, what we do is we make a tiny puncture in the vein that is affected, or the varicose veins, and we put up a probe, a small tube, and that tube at the tip, there is a heater probe. And we basically close that vein because it's backflowing down. We prevent the backflow down by closing the vein by using the heater probe. And once that's done, we remove the probe, and that's done usually very quickly in under an hour, and the vein remains permanently closed. All right. Sometimes we can use, instead of a heater source, we use glue. We use medical grade glue to fill up the vein and compress it so that it seals the veins shut. Some other methods include using a mechanical device to sort of irritate the vein and scar it from the inside before we inject a sclerosant to sort of scar the vein close. And now we frequently combine that procedure with another procedure where we treat the small spider reticular veins, because bear in mind, not only are the big ugly varicose veins present, sometimes around it you've got these small spider veins, and we do something called a cryo-laser and cryo-sclerotherapy, something called a CLEX procedure, in which we use a laser and we basically cool the skin down with cold air, and then we basically use a laser and some chemicals that are injected into the small tiny veins to scar them and remove them. Now, the advantage of doing this is you leave behind very little pigmentation and almost no scars, and you sometimes cannot see them. So this is a short video on the CLEX procedure.
If you are facing problems with spider and reticular veins, CLEX is a minimally invasive procedure which you can turn to. It stands for cryo-laser and cryo-sclerotherapy. Here, both the transdermal laser and skin cooling under -20 degrees Celsius are used to reduce the appearance of spider and reticular veins. The injection of a sclerosant in this video also shrinks the veins. Vein walls are damaged, veins become smaller, and pain and swelling is relieved. In these before and after photographs, you can see how effective CLEX is. This minimally invasive procedure leaves no scars, no stains, and no pigmentation. You can expect a quick recovery time, minimal discomfort, and no use of anesthesia. Find out if this treatment is suitable for you today.
This is all the vein procedures that we are talking about, including the CLEX, can be done as an outpatient. And in fact, for the CLEX, we do it like a clinic visit. Patients drop by during their lunchtime, get it done in about half an hour, and then they go back and they continue the activities. So very, very effective ways of treating lower limb varicose veins. I'm going to switch gears now and move to something that it is a little bit more complicated, but also affects many women, and that's pelvic congestion syndrome. Now, what is pelvic congestion syndrome? Simply put, it is varicose veins, but this time affecting the pelvis. In other words, affecting the vessels or the veins around the womb and the ovaries. Now, basically, again, the same problem. It is also due to blood pooling, and this causes pain and swelling, and causes constant pain and swelling, especially in the pelvis. So many women describe a sensation of fullness, that when they sit or stand for long, they feel as though there's something pressing inside the pelvis. Sometimes it can feel irritated, they feel weak. And in 30% of women with this problem, it can cause chronic pelvic pain. Aching pain, as I said, is usually present, and it is worsened actually during menstruation, sometimes during coitus or intercourse, and sometimes urination. It can also translate down to heaviness and swelling of both legs, because these veins can sometimes drain downwards towards the legs. And sometimes patients have dilated, ugly varicose veins around the buttocks, their groin, and around their genitalia. So these are all signs that a patient may have pelvic congestion syndrome. How do we diagnose or screen for pelvic congestion syndrome? Usually we do an ultrasound scan. Sometimes we do a CT, and that is good enough for us to see. Now, again, what are the risk factors for pelvic congestion syndrome? They're very similar to risk factors for varicose veins. Again, multiple pregnancies is one of the most common reasons why women develop pelvic congestion syndrome, usually 2 or more pregnancies again, and especially if baby in the womb was very big size. In other words, women who deliver children or babies who have a higher birth weight are also at increased risk. All right, and this causes pelvic congestion syndrome. Now, once we diagnosed it, and that's usually on an ultrasound or a CT scan, we treat depending on whether the patients have severe symptoms. Now, the patients that I see, many of them either feel very uncomfortable and have chronic pelvic pain, and they have actually been seen by many other doctors, including colorectal surgeons, gastroenterology surgeons, because they think it's a colonic problem. They have had multiple OBGYN workups for fibroids, for endometriosis, and found to be negative. And in the end, we find that they have PCS, and many women are not able to function because of this pain. Some other women have very heavy menstrual cycles that sometimes lead to anemia. Some women have very painful coitus and affects their social lives. So in those cases, we then advocate treatment. And the first line of treatment is sometimes we try giving some medication to relieve the pain. But again, if it doesn't work, then we move to more definitive treatment. And this is usually minimally invasive and done as a day surgery procedure under local anesthesia and sedation. And this is a procedure called ovarian vein embolization. Now, the problem with varicose veins of the pelvis, or PCS, is that there is a particular vein that leads down towards the womb and the ovaries in that region, and that's the ovarian vein. And essentially, that vein becomes enlarged and very congested. And what we do is, under X-ray guidance, a catheter is then put in through the groin vein and pushed into this vein, this particular ovarian vein, and we do it under X-ray guidance. And then we block off the vein, pretty much like how we do for the legs, where we use a heater source to sort of close the vein off. This time around, we can't heat it close, but we block it off with particles or coils. And this procedure is very fast. It's done usually in under an hour. You don't need any open surgery, and patients recover very fast and go back to return to the daily activities. Okay, Okay, this is a case where essentially we see a patient with pelvic congestion syndrome, and then you see coils being inserted in. Okay, and this is how we block off the vessels that cause it. And after we're done, essentially there's very, very little flow. This is again before, and this is after the coiling. And it's almost an immediate relief of symptoms. All right. So that's where I end my talk about pelvic congestion syndrome. I'm happy to take questions with the rest of the panelists soon, and they'll be joining me. Thank you very much.